Thanks for a wonderful presentation. Regarding the educational aspect, as the professor of geriatric medicine who teaches 60 hours a year of in classroom, the big disconnect and opportunity we have for this next generation is they all learn in the classroom with Roger and myself and a small band of people, the core curriculum that's required for the LMCC exam, and our medical students score highest in the country on that piece, and our medical residents and family medicine residents have excellent training. The piece that's missing is for them to go out and apply this knowledge in a system of elder care. And so without that, they have the textbook knowledge, but not the practical experience of working with all the wonderful people in this room and applying that knowledge. That's what I think is the big disconnect. Thanks.
Thanks for the presentation. The last slide I particularly liked in terms of the process improvement, in terms of being able to collect the data points that you want to be able to collect on it in order to be able to make informed decisions using evidence, which is a good thing because there's too much that happens from an anecdotal nature.
Right.
You take a look at it and say, well, you scan a place and take a look at it, but you actually need robust data, probably a good collection system so that you can trust the data that you have, so that you can make good decisions based on it.
Sure.
So
I'm basically a researcher by mind, right?
Okay.
So I don't go by anecdotal. I'm an evidence-mind person,
yep.
And it's basically that's the reason we have to have certain scales and measures, tools that give us a baseline information,
mm-hmm.
and a follow-up information,
yep.
And also we need to put in some measures in place to see how much cost saving or burden on resources it's going to impact upon resources, because assumption is that this model will save money, lessen the burden on the resources, and improve outcome. All three, right?
Yep. And if you collect robust data, then you'll actually be able to show that one way or another. But that process is something that should be used throughout the entire organization.
Definitely.
In my opinion.
Right, yes.
Yeah.
Yeah.
So thanks for the last slide was excellent. Yeah.
Paul Bonesteel. In 1985, the Royal Commission on Healthcare in this province basically stated that if you want to spend less money in hospitals, you have to spend more money in the community.
Exactly.
It has to be a shift of resources. 25 years later, we still haven't heeded that advice. We've taken small steps, but only small steps, small, cautious, wimpy steps towards what needs to get done. When we listen to the discussion across the country about what are we going to do with healthcare, the sky is falling, the Chicken Little approach, it reminds me of the question, how do you eat an elephant? The answer is one bite at a time. And we're so overwhelmed with the task of changing the elephant that is our healthcare system, that it's keeping us from moving forward. It's delaying our momentum, and we're not moving forward into small, manageable bites. All the speakers this morning have basically said that models that keep people out of hospital cost less, and in fact they do. And I think if we're going to take steps to get the movers and shakers to shift money, we have to present a business case. Show
Yes.
them the money.
Right.
Show them the figures. I think this is where we might prod them into action.
You hit it on the head, right? It's basically that is the issue. And I've started telling people openly that I have in my mind, the reason I stayed here honestly was for MUN. I'm with Memorial University. This is a very nice university. I was not the geriatric care. I'm very passionate about geriatric psychiatry, geriatric care. That was not the drive for me to keep me in this province. And I was telling Pat the other day, and Roger, that I have in my mind set summer of 2012 as the deadline. If I don't see that we as professionals or the policymakers are making progress, I'm going to change the sides. I'm going to go on the public side. I'm going to advocate from their side and start doing forums or whatever I need to do. And I have done that. In my careers, I have done that. So it's going to be time intensive because we need to build the pressure from the consumer. And I know that very well. I was on the International Consumer Association for 6 years. So this is my last shot, basically. So I'm very hopeful. And
Well, let's make it a good one. Let's have a round of applause. Thank you so much. All right, so we've got some food stock now. That's something for us to chew on and reflect on. So what we're going to do now is we're going to take a break for 20 minutes. And when we come back, some of this equipment is going to be gone because we won't need it anymore. Media will be gone. And what I'd like for us to do is to have a discussion around, well, first of all, let's get a little bit of reality check in terms of some of the barriers that that exist that keep the status quo in operation. But then also then move on to what are some of the elements or the foundational elements in a model of medical care and treatment for seniors. And that's going to be good stock then for the work that you're going to do after lunch in terms of developing a model.